Hello, and welcome to today's webinar, Changing Perception, How to Build Cultural Competence and Humility. Slide. My name is Joanne Jung, and I'm a Commonwealth Fund Mongan Fellow in Minority Health Policy at Harvard Medical School. Before coming to Harvard, I worked as a pediatrician at a federally qualified health center serving mostly immigrants and refugees in Oakland, California. I'm also a member of the National Center for Medical Home Implementation Project Advisory Committee and chair of the National Center's work group responsible for the development of this webinar. This webinar is the first installment of the 2016 webinar series entitled Thinking Outside the Box, How to Advance Health Equity and Care Quality in the Pediatric Medical Home. This webinar series is presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal and Child Health Bureau of the Health Resources and Services Administration. Before our faculty begin, I'd like to inform you of some housekeeping items. The slides will appear in the central window of your screen and will advance automatically. We encourage you to ask questions throughout the presentation using the question box window on the left-hand side of the screen. These questions will be answered at the end of the presentation. If we do not have time to answer your questions during the webinar, we will send you an answer directly via email at a later time. This webinar will be recorded and archived on the National Center for Medical Home Implementation website approximately 1 week after this presentation. After the webinar, you will also receive an email with a link to the webinar evaluation. We encourage you to complete this evaluation so that we can continue to improve the content and manner of our presentations in the future. Next slide. Today's presenters have no financial or conflict of interest disclosures to announce. Next slide. Today's webinar has 3 learning objectives, including the following. Define cultural diversity and discuss the importance of recognizing cultural diversity among all patients, families, and clinicians. Describe how acknowledging and minimizing unconscious biases can improve cultural competence and quality of care among pediatric health professionals and the patients and families they serve. Identify evidence-based and evidence-informed tools, strategies, and promising practices that improve culturally competent healthcare delivery, including cultural humility. Next slide. Prior to joining this webinar, all registrants were sent a link to a set of implicit association tests. These tests are designed to assess your attitudes or beliefs towards a specific topic, and as such, help to identify unconscious biases. Throughout this webinar, we'll discuss how unconscious bias can impact cultural competence in healthcare. And now, I'm honored to introduce to you today's first speaker, Dr. Joseph Betancourt. Dr. Betancourt is the Director of the Disparity Solution Center at Massachusetts General Hospital. The Disparity Solution Center is dedicated to the development and implementation of policy and practice to eliminate racial and ethnic disparities in healthcare. Dr. Betancourt.
Great. Thank you all so much for being on today. Thank you, Joanne, for the introduction, and also thanks to my colleague, Dr. Glenn Flores, who I've known for many years and I have the pleasure of reconnecting with and getting a chance to humbly share thoughts about work that is near and dear to my heart and certainly I think important for all on the call. By way of background, I'll just talk a little bit about who I am, what I do, and then jump into level set on the topic of cross-cultural care, cultural competence, and humility, and to set the stage for the discussion and a presentation on some practical applications and tools around this topic. So I'm a practicing internist, spend around 30% of my time practicing primary care internal medicine, and also direct, as was mentioned, the Disparity Solution Center, where we work with hospitals, health plans, health centers across the country to better identify and address racial and ethnic disparities in healthcare. Within that context, I've had the great pleasure and honor of working quite a bit on the topic of cross-cultural care and communication both in the academic world and in practice as Director of Multicultural Education at our hospital, Mass General, where we've deployed a set of curricula for our doctors, nurses, and frontline staff with a particular focus on value, performance, and improving communication, tracking that by patient experience. So long way of saying that this is work that's very, very important to me. Firmly believe that it's important, certainly, that we as caregivers, no matter what our role, are prepared to care for anyone from anywhere at any time at a high level. Originally, by background, I'm from Puerto Rico, grew up in a bilingual, bicultural home, served as an interpreter for my grandmother as a child. So the issues of race, ethnicity, culture, and language were something that I got to see at a very young age, and have really tried to focus on professionally how we as a healthcare system can meet the needs of diverse patient populations. I wanted to simply begin with the premise that brings us all together. If we could go to the next slide. Why are we here? Why are we discussing this issue? And why is this important? So let me begin by saying I think we could all acknowledge as caregivers that we strive to deliver high-quality care to, again, anyone we see from anywhere at any time. This issue is certainly, our success doing this is certainly predicated on how well we're able to communicate, build trust, and secure cooperation from the patients and families that we interact with. And at the end of the day, we understand it's not rocket science. Communication really matters. There's no doubt that communication and our ability to communicate effectively is challenged by the oftentimes urgency of the situations in which we're communicating with patients and families, and in particular the amount of time we have in what are often very short and very packed clinical visits. So what we understand is that it is, in a short amount of time, covering a lot of issues, harder to communicate with some than others, especially across cultures. And when I say across cultures, I don't just mean when the provider and patient is of a different cultural background. I also am acknowledging the fact that we in healthcare have our own culture, our own language that we speak, our own way of operating, and patients and families, no matter what their stripe, have their own culture and set of perspectives. So really, every encounter becomes a crossing of multiple cultures. Number one, the medical culture to the patient's culture, to the patient culture in general, but also more specifically to the culture of the caregiver and the specific culture of the patient. So we're trying to navigate what are a complex set of perspectives, beliefs, behaviors, motivations, again, in a short amount of time. And as I mentioned, and as research has demonstrated, those individuals who are at a greater distance from the Western medical model, those individuals who are less facile around health care and communication, health literacy, patient navigation, activation, shared decision-making, tend to present, I think, more challenges for us as caregivers as we try to manage their care. Now, the next key part of the premise is that there's no doubt that now more than ever before we need to be skilled at communicating and conveying lots of information in a short amount of time, often in critical situations. Now, as caregivers, what we know is that when we are ineffective, we get frustrated, and patients receive lower quality of care. And so we also understand that if we are to deliver high-quality care, we must be skilled at communicating and caring for all patients. And this does require a skill set, an approach, a framework, a checklist, if you will, to assure we are prepared and able. I'll just end by saying that I think we understand that bedside manner, the ability to develop rapport, and being kind and thoughtful is critically important in our care and communication of patients and families. At the end of the day, though, what we understand is that is often not enough. We need skills and we need an approach as we're trying to navigate multiple issues in clinical encounters all day long. If we could go to the next slide, I want to begin and reiterate a couple of key principles that we're going to touch on today that I think are very, very important. Number one, when we talk about culture, as I mentioned, we're defining it broadly. So it's not just race, ethnicity. We're not trying to put people in categories or, kind of give you the key do's and don'ts. We are going to give you some thoughts and perspectives about different populations. But at the end of the day, what we understand is we all have culture. We are crossing the medical and patient culture, and there is great variation within cultural groups. So every individual patient brings their own social and cultural perspectives to their interactions with us, and we need to be cognizant of that. So again, a long way of saying that for some patients, these issues that we'll discuss today may not bubble up and may not impede our care, communication, and cooperation with patients and families. For others, they might be quite prominent, and it is in those situations when triggered by certain key factors like patient or family not at target, patient or family refusing something that might help save their lives, patient and or family missing visits, oftentimes not following up. These are triggers that there are certain other things going on that we may then want to deploy a set of tools and skills to better explore, and we shouldn't leave the issues of cultural perspectives aside. We should incorporate them into our exploration. So again, great variation within cultural groups, and I think that's a really critical point. Next slide, please. So what are the challenges that we see communicating across cultures? So there's no doubt that an individual's social and cultural background will impact their health beliefs, behaviors, and treatment. This manifests in many, many different ways over the course of a clinical encounter, including the way patients present their symptoms. We in healthcare are taught how patients might express their symptoms. This could be very, very different, and we know as caregivers it's quite different. We talk oftentimes of the textbook presentation and how rare that is. That's because people will use their own words, their own perspectives will shape how they express their symptoms to us. Having a good, broad radar to pick these up across cultures is absolutely essential. An individual's social and cultural background will certainly impact their expectations of care, whether it be somebody who's come from an environment where they haven't received much care at all and they feel like they need to tell their provider everything even though it's not particularly important to them, or somebody who is used to just managing and will minimize and just say yes, yes, yes a lot when asked questions because they view the healthcare provider as an authority figure. These are the variations in expectations of how care is managed and how patients interact with us that we need to be attentive to and help focus on and solve. Certainly an individual's social and cultural background will impact their ability to maneuver within what is a very complex healthcare system. And this is often, again, dependent on an individual's previous healthcare experience, what they're used to. Patients and families aren't given a manual on how to interact with the healthcare system. So being aware of what their previous healthcare experience is like and what they're used to will, again, be very, very helpful as we help them navigate the system, again, impacted by their social and cultural background. And finally, their social and cultural background will impact their diagnostic and treatment choices, often in ways that might seem counterintuitive to us. Individuals refusing things, again, that we think are important, taking different paths that oftentimes frustrate us or seem difficult, but in essence, gaining a better understanding of that puts us in a much better position to negotiate and come to some common ground about what we think might be best for them and their care, bringing our expertise to bear. Next slide, please. The research tells us a couple of things that I want to focus on here. Particularly as it relates to the importance of cross-cultural care and the link to disparities in care, which are quite simply variations in the quality of care patients receive when you stratify by race, ethnicity. So let me highlight a couple. Number one, we understand that all patients have difficulty communicating with their healthcare providers for a variety of different reasons. This is a large survey from the Commonwealth Fund which highlighted that, in fact, 1 in 5 patients, 1 in 5 of all patients, and about 16% of white patients, feel that over the course of the last 2 years when they've seen their healthcare provider, they've had difficulty understanding them, not necessarily felt like the caregiver has listened to them, and they've had questions that they hadn't felt comfortable asking. When you stratify by race ethnicity, though, you see that for certain populations, these issues are even more prominent. Almost 1 in 4 African Americans report 1 or more of these communication difficulties with their caregiver. About 1 in 3 Hispanic Latinos as well. Almost 1 in 3 Asian Americans. Certainly there's incredible diversity within these groups, but this gives us a rough target to understand that if we acknowledge how important communication is, improving our ability to communicate with populations who have difficulty communicating with us will allow us to limit variations in quality and care that lead to some of the disparities that I'll highlight in a few moments. Next slide, please. Another key issue that we see that's quite important and that we understand is the issue of trust. Undoubtedly, it is absolutely essential that patients and families have trust in us as caregivers. Trust is essential to the therapeutic relationship. We also understand that patients and families may be mistrustful of healthcare for an entire set of reasons, a whole variety of reasons that we may not have any responsibility for. So in essence, we might see a patient for the first time. We've done nothing to engender any mistrust, but for a variety of different reasons, mistrust sits in that room with us. It is absolutely essential, and I would argue our responsibility to be able to assess whether there's mistrust and to do the best we can to trust build. And the research bears that out, that again, particularly for certain populations, mistrust is quite prominent. When surveyed, for example, minority populations that you see here report at greater rates that they've been treated unfairly in the past based on their race and ethnicity, and perhaps more concerning, are worried that they're going to be treated unfairly in the future based on their race and ethnicity in the healthcare system. A long way of saying that a key part of cultural competence, cultural humility, and cross-cultural communication is utilizing trust-building skills that will be helpful for all patients, but might particularly be helpful for those patients who are vulnerable and who are mistrustful due to issues like a bad healthcare experience. Their families had 2 issues of racism, discrimination, segregation, medical experimentation, and the often cited Tuskegee syphilis study just as examples. So trust becomes, and addressing mistrust becomes another key issue here. We could go on to the next slide, please. Another key issue that we are trying to address through this work includes better understanding how we as caregivers make clinical decisions. Now, again, a lot of the research tells us, and research about medical education tells us that we are raised in a culture that teaches us to advocate to the best of our abilities for every patient. And in many ways, we are raised in a culture in medical education to believe that we should be making clinical decisions with blinders on to personal characteristics, but focus on science and symptoms. And although that is a laudable and I think very noble goal, the truth of how decisions in general get made differs substantially from that. And the net here is that we as caregivers are human beings like anybody else, and despite what we're taught, we are susceptible, like anyone else, to making assumptions or making stereotypes about individuals or about situations based on our previous experiences, conscious or subconscious. In the clinical world, this is incredibly helpful, right? I often talk about the fact that as caregivers, when we first see a patient who's sick, we might need to get some data to understand that they are sick. But after we see enough sick patients over the course of our training and in practice, boy, we could just walk into a room, look at somebody, and just by the way they're breathing, by the way their eyes look, by the way they're seated in bed or present to us, we could quickly tell that they are sick without needing a pulse ox or a blood pressure or any other data. Why? Because we've seen enough sick patients. We've seen what being sick looks like, and so quickly we're able to identify, hey, this patient is crashing because I've seen this before. Those quick connects are very, very helpful to us clinically, and those actually are what we call cognitive heuristics. They are our mind taking information over time, identifying patterns, and then taking the shortcut and applying it so that we don't need a lot of data, and that shortcut then helps us be decisive. The truth of the matter is that's the way our mind works. We take information, we put it in folders in our heads, and our mind is constantly looking for these shortcuts to use less cognitive resources. Malcolm Gladwell wrote a great book about this called Blink that people may be familiar with that literally says, in the blink of an eye, even though we don't think we do it, want to do it, or believe we do it, our mind is making a decision. It's what we might call our gut instinct that looks to be effective, looks for shortcuts to drive decision-making and make it easier. And again, I've given a clinical example of how, oftentimes for us as caregivers, that is incredibly helpful. But at the end of the day, that blink process, that process of this quick connect, that process of moving to the shortcut can betray us. And it can particularly betray us as it relates to how we view and interact with people. Not unlike any other human being, we as caregivers when faced with complex information, put information in folders in our heads, look for shortcuts. And as it relates to our interaction with people, we automatically do this. We take group characteristics, experiences we've had with certain types of individuals who look a certain way, who act a certain way, who speak a certain way, and we automatically apply them to that individual, again, even if we don't want to. We take group characteristics and apply them to the individual. Again, we do this because all humans are built to look for cognitive shortcuts to save resources. This is a principle of least effort. And what's particularly challenging is that we make these shortcuts, our mind makes these shortcuts on things we see with our eyes, race, gender, and age. And these stereotypes, these assumptions about people are activated the most when we're stressed, when we're under time constraints, and when we're multitasking, which I'm sure we could all agree is the environment in which we practice. So we live in and work in a cauldron an environment that activates stereotypes. Now, at the end of the day, we understand that we have heard over the course of our training or in practice the term among very, very well-intentioned people, these patients, I've had this experience with them, so let's just try this kind of well-intentioned step back from quality. And in fact, a lot of this links to the disparities research where we see, for example, that if two patients present to the emergency room with chest pain, all things being equal about them except for the color of their skin, minority patients significantly less likely to be referred for cardiac catheterization, angioplasty, bypass surgery, cardiology specialist care. We also understand that if three patients, white, black, and a Latino patient, present to emergency rooms around the country with a long bone fracture of their arm or their leg, minority patients significantly less likely to be given the same amount of pain medication for the same exact fractures as their white counterparts. In the pediatric world, an article that came out within the last 6 months, maybe a little bit longer, showing those same variations in the administration of analgesia for children who presented with appendicitis. So you begin to then look at these areas where disparities play a role. You understand that communication might play a role. You understand that mistrust might play a role. But you also understand that, might caregivers be making assumptions about certain patients that then lead to slightly different decision-making patterns, such as less referral for certain tests, less provision of analgesia, less referral for renal transplantation, for example, all areas where the research has borne out significant disparities. So I'll just end this piece by saying that we have been talking about this concept of stereotyping. We've given you the implicit association test. We've been talking about this for the better part of 10 to 15 years. Medical schools, healthcare professionals are now learning more about how we make decisions, how stereotypes are made, so we could be more cognizant about them. But what's happened fundamentally is that over the last 10 years, caregivers 10 years ago would say, not me, I don't stereotype, I don't make assumptions about people. Yet if we go to the next slide, I want to highlight where we are today. A large survey by WebMD and Medscape just within the last 3 to 4 months, surveying over 16,000 clinicians across the country, getting at the issue of this exact topic of bias and stereotyping. Might you be impacted in some way? Might some bias impact your clinical caregiving or decision-making? And basically this study found among 16,000 surveyed that there's now a greater understanding, admission, and recognition among caregivers that, yes, we are all impacted by these stereotypes, and they do play out in our caregiving. So this shows that about 40% of all physicians surveyed agree that they have some types of biases that impact care. And what's particularly interesting here, as I mentioned around the cauldron of how these stereotypes have activated multitasking, stressed, under time constraints, 62% of emergency room physicians claim that biases impact their care. You understand that. They live in that environment that I just talked about. If we go to the next slide, and if you ask caregivers what particular characteristics trigger bias, you'll see here a whole list. Emotional problems, weight, intelligence, language issues, insurance, age, income, race. So this issue of stereotypes is not a question of do we or don't we. It's a question of we do, how much, and how can we mitigate their impact on our care. Next slide. As I've already covered, these issues, communication, mistrust, stereotyping, all lead to variations in care, disparities in care, that impact particularly minority and vulnerable communities. This is just a simple screenshot of unequal treatment that was a report that was released now some 14 years ago that made this very clear that, yes, there is something happening within the healthcare system that is leading to differential quality of care. Next slide. The Institute of Medicine report said many sources contribute to these disparities, like the ones I've mentioned. No one suspect, no one solution. And that we as caregivers, upping our game around cross-cultural care and communication would help us eliminate disparities and better achieve that aspirational goal of high-quality care for all. Next slide. So as we think about particularly this concept of stereotypes, we're going to talk more about communication, trust, and the like. I just want to say, take a little bit of time to learn more about this. And at the end of the day, understanding the mechanism of how stereotypes get produced, identify when you are being conditioned to fall into these traps, double-checking your clinical decision-making, working in diverse teams, using skills to avoid reifying stereotypes are all important strategies to, I think, better achieve the goal of communicating and caring for all people at a high level of quality. Next slide. I'll end here by saying that we are in the midst of some incredible healthcare transformation. And again, there's this understanding that lack of communication impacts quality, drives up costs. If we look at many of the pressure points in healthcare, there's a clear understanding that doing better in this area will help us improve quality, value, cost, and safety. Last slide. What we hope to impart on you here and share with you is that what we're talking about around cultural competence and cross-cultural communication, the simple goal is how do we improve our ability to effectively communicate with and care for patients from diverse social and cultural backgrounds. I hope that was helpful to level set. I look forward to questions towards the end, and I want to turn the presentation back over to Joanne and to my good friend and colleague, Glenn Flores. Thank you.
Thank you so much, Dr. Betancourt. And now it's my pleasure to introduce our second speaker, Dr. Glenn Flores. Dr. Flores is a pediatrician and Distinguished Chair of Health Policy Research at the Medica Research Institute and a research affiliate in the Mayo Clinic's Department of Health Sciences Research. He's a member of the American Pediatric Society Council, the editorial board of the Journal of Healthcare for the Poor and Underserved, the National Advisory Committee of the R.W.J. Amos Medical Faculty Development Program, and the mayor of Minneapolis' Cradle to K Cabinet. His 214 publications address a variety of research and policy issues, including cultural competency, language barriers in healthcare, health disparities and equity, and improving the health and healthcare of underserved children. Dr. Flores?
Well, thank you for that very kind introduction, and it's a pleasure to have this opportunity to speak with you all. Next slide. I'm going to talk about achieving cultural competency in pediatric care, a data-driven approach. Next slide. So why is cultural competency so important to healthcare? Well, the world's population of 7.3 billion people inhabits 191 countries and speaks over 6,000 languages. Racial and ethnic minority children comprise 48% of U.S. children, and that's equivalent to 35 million. Census projections indicate that minority children will outnumber white children by 2018. Indeed, from 2000 to 2010, white children in America declined by 4.3 million, while Latino and Asian Pacific Islander children actually increased by 5.5 million. And in 2011, for the first time in our nation's history, minority births actually outnumbered white births. Next. Mounting evidence demonstrates the profound impact culture can have on clinical care. We know that failure to achieve cultural competency can have serious clinical consequences, which can include access to health care, health status, use of health services, patient and physician communication, satisfaction with care, medication adherence, and quality and patient safety. Next slide. So let's start with normative cultural values, which can be defined as the beliefs, ideas, and behaviors that a particular cultural group on average values and expects in interpersonal interactions. Next slide. A good example is the Navajo concept of Huzhuji, which it's important to think and speak in a positive way. Thought and language actually are believed to have the power to shape reality and control events. So the expectation is that communication between healers and patients will embody the concept of positive thoughts and words. And so negative thoughts and words are believed to cause harm. Next. The lack of awareness of Hashuji can cause inadequate discussion of medical risks, miscommunication about advance directives, and failure to obtain informed consent. As an example, a Navajo patient was told by a surgeon that in all operations there's a risk of not waking up. But the patient viewed this to be a death sentence and so refused to consent to surgery. And indeed, 86% of Navajo patients in one study said that advanced care planning is a dangerous violation of traditional Navajo values, and many would not even discuss the issue because they felt it was too dangerous. Next slide. Next, I want to talk about language barriers in terms of English proficiency in the U.S. So between 1990 and 2014, the number of people in the U.S. speaking a language other than English at home rose from 31.8 million to 63.1 million. And the number of Americans limited in English proficiency, which we also call LEP, grew from 14 million to 25.6 million. And LEP is defined as self-rated English-speaking ability of less than very well. And because we're focused on pediatrics today, about 12 million school-age children, so 22%, speak a language other than English at home, and that's actually a number which has tripled since 1979. Next slide. One study found that pediatric residents often poorly communicate with LAP families. So this was a study of a major pediatric residency program, and it found that 68% of residents spoke little or no Spanish. 53% of the non-Spanish proficient residents actually use their inadequate language skills in patient care often or daily. Many residents reported to LAP families under their care never, only sometimes understood their child's diagnosis, 53% of the time, medications, 28%, discharge instructions, 43%, and the follow-up plan at 40%. 80% of these pediatric residents avoided all communication with LAP families, and although all of them agreed that hospital interpreters are effective, 75% reported never or only sometimes using hospital interpreters. Next slide. So we also know that there's impact of language barriers in pharmacies. So one study of 128 pharmacies in a major U.S. city done by a medical student of mine with our team found that 47% of pharmacies can never, only sometimes, prepare non-English language prescription labels. Over half of pharmacies never, only sometimes, can provide non-English language information packets, and about two-thirds of pharmacies never, only sometimes, can orally communicate in non-English languages. Next slide. So we know there are lots of hazards of using ad hoc interpreters. So these are family members, friends, untrained staff, people pulled from the waiting room or even the street, and of course children. And we know that recent studies document especially egregious hazards of using ad hoc interpreters for LAP cancer patients. Examples include the physician said, "We think there is a 40% chance that the treatment will prolong your life," which the ad hoc interpreter interpreted as, "The treatment will prolong your life." One physician said the doxy could hurt your heart, which is interpreted as the doxy can give you pain. Another physician said the results of these tests lead me to conclude that you do have breast cancer, which the interpreter interpreted as, "This test will tell me if you have cancer." And one important thing that you have going for you is the fact that the cancer has probably been caught early, which was interpreted as, "One important thing is the fact that the cancer is working quickly in your body." Next slide. And we know that there are lots of these kinds of errors that occur, and I wanted to share with you an example from an article we had in the New England Journal of Medicine. This is multiple omissions and false fluency errors. This is a 12-year-old with dizziness, and he has no interpreter, so he's interpreting for both himself and his mother, and the mother said, "La semana pasada él le dio mucho mareo y yo no tenía fiebre ni nada, y la familia por parte de papá, todos padecen de diabetes," which means last week he had a lot of dizziness, and he did not have fever or anything, and his dad's family all suffer from diabetes. So, of course, the adolescent says nothing. The doctor says, And the mother says, "A mí me da miedo porque él lo que estaba mareado, y no tenía fiebre ni nada," which means I'm scared because he's dizzy, and he didn't have fever or anything. So, again, the adolescent says nothing. The doctor says, "Okay, so she's saying you look kind of yellow. Is that what she's saying?" And the patient says, "Es que si me vi amarillo," which means is it that I look yellow? And the mother said, "Estaba como mareado, como pálido," which means you are like dizzy, like pale. So the patient turns to the doctor, says, "Like I was like paralyzed," something like that. What? And we know that language affects quality and patient safety. So a study of a large children's hospital in the Pacific Northwest revealed a twofold increased risk of serious medical events in Spanish-speaking patients requesting an interpreter versus those not requesting an interpreter, and serious medical events that included tenfold medication errors, missed or delayed diagnoses, diagnostic procedures performed on the wrong patient, the wrong diagnostic procedure performed, and administration of breast milk to the wrong patient. Next slide. Some other examples from the real world. So we found in a study that a 2-year-old would fracture a clavicle after falling off her tricycle was seen by a resident physician who misinterpreted 2 Spanish words, diagnosed the child with child abuse, and contacted the Department of Social Services. Without an interpreter, had the mother sign over custody of her 2 children. Another case, a 10-month-old girl with iron deficiency anemia was given a 13-fold overdose of iron and hospitalized for iron intoxication after her LEP parents were given medication instructions and a prescription only in English. The parents actually gave 15 milliliters, so a tablespoon of iron elixir based on a prescription label that read 15 milligrams per 0.6 mLs, 1.2 milliliters daily. And of course, the famous case of a misinterpretation of a single Spanish word, intoxicado, in Florida resulted in an 18-year-old's quadriplegia after being misdiagnosed with a drug overdose. The patient's hematomas, brainstem compression, and paralysis were due to a ruptured aneurysm, and the hospital paid out $71 million in a malpractice settlement. Next slide. We also know about the positive impact of trained interpreters and bilingual clinicians. So access to appropriate language services positively impacts health outcomes. So, for example, in children presenting to the ED, LEP patients with professional interpreters did not differ from English proficient patients in test costs or use of IV hydration, and actually had a lower likelihood of testing. And in adults with hypertension and diabetes, health status, physical functioning, psychological well-being, health perceptions, and pain scores were higher in those with language concordant versus discordant physicians. Next slide. And I want to present to you a real-world case. This is Juan, who was a 6-month-old, previously healthy male who presented to a children's hospital ED with new-onset vomiting and diarrhea. The triage history given by mom was actually interpreted by Juan's 12-year-old sister. The sister stated that the patient had 4 dirty diapers and 3 episodes of vomiting that day. Juan was triaged to a non-urgent level of care in which documentation stated he had vomited 7 times that day with no diarrhea. He was discharged shortly thereafter with a diagnosis of vomiting and instructions in English only for Pedialyte PO ad lib. Next slide. 3 days later, Juan returned to the ED in severe distress with new onset of bloody stools. He was admitted to the hospital, but he died 6 hours later of septic shock. Slide. So I want to move on to folk illnesses, which can be defined as culturally constructed diagnostic categories commonly recognized by ethnic groups, and that these are also known as ethnomedical practices. The symptoms often overlap with important biomedical conditions. The first provider contact may not be a clinician. We know that some folk remedies can be harmful or even fatal, and satisfaction with care and adherence can depend on the accepting response of the healthcare provider. Next slide. An example is the Latino folk illness that we know as empacho, in which food or saliva is believed to get stuck in the stomach because of dietary indiscretion that can include eating in excess, or eating the wrong food or at a wrong time. And among Puerto Ricans in Hartford, one study found that 90% of parents knew of empacho, and 64% said that the child in the household had suffered from it in the past. Next slide. Symptoms include vomiting, diarrhea, anorexia, bloating, and fever. And so the symptoms overlap with biomedical conditions that can include gastroenteritis, milk allergy or formula intolerance, GI obstruction, intussusception, or appendicitis. Next slide. The first provider contact for empacho is not usually a physician. So the treatment choice among parents whose child had empacho in the Pachter study was a santiguadora in 77%, so that's a folk healer, a home remedy in 58%, and a doctor visit in only 37%. Only 9% of the parents reported the physician as the initial choice for treatment, and 85% of those visiting the physician for empacho sought yet another form of therapy after. Next slide. So many of the empacho treatments are harmless. They include dietary restriction, teas, abdominal massage with warm oil, and then treatment by various folk healers that go by the names of santiguadora, sobador, or curandero, or sometimes by the parents. Next slide. But we know that there are empacho treatments that are harmful or even fatal. So Mexican families may treat with powders containing high concentrations of lead. They go by the names of Greta, Azarcon, and Albayalde. And analysis has shown that the lead content varies from 70 to 97%. And multiple cases of severe lead toxicity have been reported with outcomes that include lead levels as high as 124 mics per deciliter, severe lead encephalopathy, and even death. And we know that use of lead-based empacho remedies in certain communities can run as high as 35% in Mexico and 11% here in the United States. Next slide. Other folk illnesses with potentially harmful treatments, and I have a reference up there if you want to see a full list of hundreds of them, include in Bangladesh, Pakistan, and Sri Lanka. Folk illnesses associated with infant diarrhea that go by various names include beliefs that the mother's breast milk is actually poisoned and breastfeeding must be discontinued, placing the infant at greater risk of dehydration and mortality. And for diarrhea accompanying the Swazi folk illness Umfizulu, there's a traditional vaccination procedure performed in which shallow cuts are made with a razor blade, usually not sterilized, and then rubbed with ashes. Next slide. So next I want to briefly talk about patient-parent beliefs, which can be defined as a cultural group's beliefs about disease causality, that's excluding those folk illness entities I talked about, and then the home treatments associated with these beliefs. Next slide. So many home treatments have findings that are easily confused with child abuse, and again, I would have you go to that reference if you want to see more, but here's just one example. So this is cupping or ventosas, that's pictured to the left. The procedure is you create a vacuum in a cup by burning alcohol over the inverted cup and then place the cup on affected anatomy. The practicing culture and ethnicities include Latinos and Russians. The symptoms treated can include pain, fever, poor appetite, and congestion. And the clinical presentation are these patterned circular erythematous areas, petechiae, and occasional burns. So you can see how this might easily be mistaken for abuse. Next slide. And we know that serious morbidity and fatalities can result from harmful patient and parent beliefs and practices. So, for example, lipoid pneumonia and bronchiectasis due to the application of butter or oil to the nostrils or oral pharynx of infants in India and Saudi Arabia to clean the airway and treat respiratory infections, and then opiate toxicity in infants due to the Hmong treatment of diarrhea and fever with an enema or capsule made from opium seeds. Next slide. And as Joe so elegantly presented, the biased provider practices that do occur can affect clinical care. So we know that biased attitudes and practices of certain healthcare providers can have a profound impact on clinical care, which includes access to care, impaired diagnostic evaluations, a lower quality of care, and then causing and perpetuating racial and ethnic disparities in healthcare. Next slide. So an example are provider practices in child abuse evaluations. So a JAMA study found that when looking at 388 children 0 to 3 years old who were hospitalized for skull or long bone fractures, among the 1 to 3-year-olds, minority children were significantly more likely than white children to have a skeletal survey performed, the odds of about 9, and then to be reported ultimately to Child Protective Services for suspected abuse with over 4 times the odds. Next slide. So I want to finish up with a model on achieving cultural competency in pediatrics. And in this model, cultural competency is achieved by recognizing and appropriately addressing the cultural issues that affect the clinical care of patients and families in your practice. The model components include normative cultural values, language issues, folk illnesses, patient-parent beliefs, and provider practices, all of the areas we just reviewed. Next slide. So in terms of normative cultural values, you need to identify those that affect care and then accommodate for these values in the clinical encounter. In terms of language issues, access trained professional interpreters for LEP patients and families unless you're truly fluent in the patient's primary language. Ensure comprehensive language access, including multilingual receptionists and phone trees for making appointments, and multilingual signage, consent forms, patient information materials, and prescriptions. And encourage the efforts to increase foreign language skills of staff and English skills of LEP patients. So, for example, for free or low-cost parent English classes, you can go to www.literacydirectory.org and then put in your family's zip code, and it will instantly identify low or no-cost English classes. Next slide. In In terms of folk illnesses, recognize those that affect care in your practice. You can partner with traditional healers and folk medicine stores as well. Suggest harmless alternatives to harmful folk remedies. Accommodate them non-judgmentally into the clinical encounter. Integrate them into the treatment plan whenever possible. And for patient and parent beliefs, identify those that affect care. Ask the parents about their perspectives on the child's illness, for example. Suggest harmless alternatives to harmful remedies, and carefully explain the etiology and treatment rationale for biomedical conditions. Next slide. In terms of provider practices, maintain vigilance for racial and ethnic disparities in screening, prescriptions, procedures, and outcomes. And when disparities do occur, determine the problem source and address practices that might be responsible. Next slide. So you might be asking me, hey Glenn, does cultural competency, does it really make a difference? And we actually know that it does. So a study of cultural competency policies and other predictors of asthma care quality for Medicaid-insured children found that in multivariable analyses, patients of practice sites with the highest cultural competence scores were less likely to underuse preventive asthma medications at an odds of 0.15 for the highest versus the lowest categories, and had significantly better parent ratings of the overall quality of asthma care. Next slide. So in conclusion, failure to provide culturally competent pediatric care can have serious clinical consequences, including patient injury and death. Use of a data-driven model can allow you to achieve cultural competency, and the highest quality of care and best outcomes are attained by culturally competent clinicians. Thank you.
Thank you very much, Dr. Flores. Before we move on to take some audience questions, I wanted to share some valuable resources that are available to help with building cultural competence and humility in the context of the pediatric medical home. These slides will be available to the audience after this presentation, and all resources in these slides are hyperlinked as well. As you can see on there, I just wanted to highlight a few for you. Some available directly through the National Center for Medical Home Implementation. The AAP, the American Academy of Pediatrics, specifically has a number of toolkits that have been very helpful, including one on immigrant child health, another on culturally effective care. There are some other resources in addition that I wanted to highlight on the next slide, please. All of you should have gotten a link to the implicit association test. I found this to be a real eye-opener when it comes to unconscious bias and ways in which they may be working, like under the surface. And I highly recommend the unequal treatment publication that Dr. Betancourt had mentioned earlier in his talk. So I'm taking some questions from the audience. Wanted to start with one, and I'll direct this first one to Dr. Glenn Flores as a pediatrician. I struggled with how to integrate anticipatory guidance, which for low context cultures includes a lot of written information like Bright Futures handouts, but may not be as effective in high context cultures and those with low English literacy rates, as I'm caring for now. So given culturally diverse audiences and different English language and literacy abilities within our patient populations, any advice for giving anticipatory guidance to families?
So thank you. That's a really interesting question. So one interesting study that comes to mind is Lee Pachter a while back showed that there are actual cultural differences and racial and ethnic differences in expectations in terms of early milestones. So we actually found in that study, I believe it was Afro-Caribbean and African-American families were more focused on some of the gross motor milestones, and they wanted to see earlier achievement of those milestones. I think he also found that for Latinos, whereas the white families were more focused on the verbal milestones. And so I think that's one thing that you want to take into account is to find out what are the concerns about the families. But of course, regardless of that, we want to see all kids achieve their milestones at the right time in their development. And so I think it's important to think through how we provide anticipatory guidance in a culturally competent way. And as alluded to in the question, I think one of the most important things is make sure there are no language barriers. So first of all, always use an interpreter or bilingual provider to ask about the different developmental milestones, because otherwise you may not get an accurate picture and you may miss something like, let's say, early signs and symptoms of autism. and then it's important also to translate the materials in terms of you're having the parents fill out some sort of screening instrument. You want to make sure that it's not only in their language, but of course it's also at the appropriate literacy level, and I think we still have a lot of room for improvement in medicine in general in terms of the literacy levels of a lot of the instruments that we give out. So I think that combination of approaches will be very helpful in assessing children and having discussions with families from a wide variety of backgrounds.
Wonderful. Thank you so much, Dr. Flores. This next question I'll address to the both of you, Dr. Betancourt and Dr. Flores. How do you address, in a culturally appropriate way, potentially harmful medicinal practices that you may suspect may be happening within the family?
I'll take a start at it. I mean, I think one of the most important issues here is creating the safe space in the clinical visit for the family to be able to share this information with you. Plenty of research has shown that patients and families use complementary, alternative, or folk remedies at very high rates, yet they're and will spend out of pocket for them, yet they do not feel comfortable sharing that information with their caregiver. So just to kind of foundationally say that we believe it's important that as caregivers, we don't ask what medications are you on, but then we instead change that question to what are you taking for your condition and are you seeing anybody else for it? That simply opens it up so that the individual in front of you understands that you're not just asking about the types of things I might give you, medications as we define them in kind of Western medicine or in the biomedical model, but instead opening it up so that we can understand what treatments might you be taking for your condition as you understand it. Once you've done that, you find out then, you know, as Glenn mentioned, what people might be using. Now, it could range from something that is simple and not dangerous to something that could be life-threatening. I think at that point, the opportunity, if it's simple and not life-threatening, is to negotiate, right? To say, well, certainly that's something that you can go ahead and use, and it's not an issue. I oftentimes caution my patients around how much they're spending over the counter and kind of caution them that there's a lot of people out there selling things that you know, don't necessarily bring benefits, so I have a brief conversation about that. If it is something that I deem as life-threatening, then you can't necessarily negotiate at that point in a respectful way. You share your expertise, your thoughts, that in your experience, those types of things could be very, very dangerous and actually very, very harmful. And that instead you might want to try something that's harmless and perhaps give some examples, or you know, at a minimum assure that they are unable to, that they will no longer use those types of remedies. I think the real key thing here is it needs to be done in a respectful, not scolding way. I think you do need to bring the sense that it is urgent that you not do these things, but by the same token, not do it in a way where they feel disrespected and the like, and feel talked down to. And I think people could be, you know, very effective following that kind of pattern of thought.
Wonderful.
Yeah, I agree with Dr. Betancourt, and I would start by suggesting the harmless alternatives that are acceptable in the culture. So we talked about empacho, how you have those lead-containing powders. You can say, well, instead, why don't we think about massage with warm oil? I think you want to carefully go over the biomedical rationale for that part of the treatment. You want to integrate the alternative into the treatment plan whenever possible. So one of my favorite stories from a colleague of mine who's an anthropologist and pediatrician is that at the time, you may remember that we once treated with albuterol syrup for wheezing and for bronchiolitis, and one of the common folk treatments in the Latino community was something called siete jarabes, which means 7 syrups. And so Dr. Pachter noted that the family was giving the child this ethnomedical treatment, and he said, hey, you know, I know that can be helpful, but how about we do 8 jarabes? And what he did was he added the albuterol syrup to the siete jarabes, and the family was happy, and the child did better at the time. And then the other piece would be to work with ethnomedical healers. And so a great story that I also heard from the same colleague was he had a child who was being hospitalized for dehydration and gastroenteritis, and he was talking to the family and being respectful and said, well, what do you think the child has? And they said, well, this child has empacho. So he gave the child IV fluids, but also called in a santiguadora, a ethnomedical healer from the community, who came in and gave massage with warm oil, and the child got better a week later, he gets a call from the ethnomedical healer who says that, hey, Dr. Proctor, I'm having trouble with this rash. Can I send this kid into your clinic? And I thought that was such a great example of synergy and respecting the community and the family's beliefs so that everything worked better even when you do biomedical and the alternative healing at the same time.
Wonderful. A lot of great questions have come in. Unfortunately, we won't have time for them all today. But a few people did ask about reflecting on the similarities and differences between the terms cultural competency and cultural humility. And noting that there's some commonalities but also some distinctions between these two terms, would you care to reflect? And I'll direct this to the both of you as well.
I'm happy to start. I mean, I have to admit that I really don't get caught up in the particulars of these terms. At the end of the day, there's a lot of terms that are used, and really what they're trying to do is achieve the same goal. So whether it be cultural competence, cultural sensitivity, cultural proficiency, cultural humility, I tend to focus less on, this concept that, of course, no one's ever going to be fully culturally competent. We're always going to be learning. Of course, from the standpoint of sensitivity, yes, we need more than sensitivity. We need skills. Of course, from the standpoint of humility, of course, you need to be humble and demonstrate curiosity, empathy, and respect. So, all those terms you can make arguments for. At the end of the day, what all of those areas are trying to do is backfill the simple set of tools and skills that allow us to make sure that we're aware and effective at addressing social and cultural perspectives that might impact care. So that's just the way I get caught up less in the particular terms and arguing for and or against them, and more on focusing on the aspirational goal of what can we do to make sure we're best prepared to care from anyone, from anywhere at any time. What skills do we need to do that, and that we're committed to doing that and learning to do it better every day.
Thank you. I believe we have time for one more question here, and this is a very practical one. How do you sensitively insist on an interpreter when the family insists they don't need one, but you think they do?
I can take a crack at that. So what I've been advocating for around the country, and I think there's starting to be some uptake, is that you really need to do a quick assessment of a patient or family's limited English proficiency. And so the census got it right, in my opinion, where they ask, is there a language spoken other than English at home? If they say yes, then you say, what is that? And then you ask the parent usually, how would you rate your ability to speak English? And your choices are very well, not at all. And anything less than very well requires an interpreter. And what I would then talk to the family about is there's now really strong evidence that, in fact, when you have an LEP patient in a family, that they're going to be subjected to a much higher risk of adverse outcomes and inferior quality of care, and there may even be patient safety issues. And so I think one way is to talk about the importance of the evidence that shows that this is important for you to have an interpreter. I think another important issue to emphasize is that you really want to make sure you understand what's going on with this patient, and to do so, you don't want any language barriers to interfere. And so I would tell patients that, and then also reassure them. Some of these patients are a little worried that because of some anti-immigrant sentiment that we know is really going around the country right now, that they may be discriminated against. So I think it's important also to reassure. And then if you have bilingual clinicians, of course, that can eliminate usually that dis-ease with having an interpreter. So that would be my advice.
Wonderful. Well, in the interest of time, I'm going to have to close out this question and answer time. For those whose questions didn't get addressed on the webinar today, we will be emailing responses. And I'd like to thank everyone so much for your questions, and another hearty thanks to our faculty members. We really appreciate your time, sharing your experiences, and your expertise with us. This webinar recording, slides, and unanswered questions will be archived about a week from today on the National Center for Medical Home Implementation website. In addition, you'll receive an email after this webinar shortly, and we'll be asking you to complete an evaluation, which will only take a few minutes of your time. We'd greatly appreciate it if we could get your feedback. The National Center for Medical Home Implementation houses a number of pediatric medical home implementation resources on their website. Please visit the links on your screen for more information, and do not hesitate to contact the National Center for Individual Technical Assistance using the contact information displayed on your screen. And this has been the first installment of our 2016 webinar series titled Thinking Outside the Box, How to Advance Health Equity and Care Quality in the Pediatric Medical Home. The second webinar in this series, Changing Relationships, How to Foster Effective Communication with Patients and Families, will take place on May 31st, 2016 at 11 a.m. Central Time. Registration information can be found on the National Center for Medical Home Implementation website by following the links shown on your screen. And thank you all very much for your participation.